male reproductive system. The male reproductive system comprises the testes, genital ducts, scrotum, penis, and accessory glands seminal vesicles, prostate gland, and bulbourethral glands, of Cowper. These accessory glands secrete the noncellular components of the semen that nourish the spermatozoa and provide a fluid medium for the delivery of the semen. The penis is not only the organ of delivery of semen into the female reproductive tract, but it also delivers urine outside the body. The testes form spermatozoa, the male gametes, and synthesize, store, and release testosterone, the male sex hormone, Fig 21.1. Glands secrete the noncellular components of the semen that nourish the spermatozoa and provide a fluid medium for the delivery of the semen. The penis is not only the organ of delivery of semen into the female reproductive tract, but it also delivers urine outside the body. The testes form spermatozoa, the male gametes, and synthesize, store, and release testosterone, the male sex hormone, Fig 21.1. The testes, Fig 21.2, are the paired male sex organs located in the scrotum that produce sperm and testosterone. Each testis of an adult is approximately 4 cm long, 2 to 3 cm wide, and 3 cm thick. During embryogenesis, the testes develop on the posterior abdominal wall behind the peritoneum and descend through the abdominal wall into the scrotum, taking coverings of the abdominal wall with them, which become tunicae of the testes. Tunica vaginalis is a serous SAE derived from the peritoneum that nearly encases the testis, and tunica vasculosa is the vascular capsule of the testis. Mediastinum testis represents the posterior thickened portion of the tunica albuginea housing the rete testis. Lobule testis consists of approximately 250 pyramid-shaped compartments housing a vascular connective tissue that envelopes the seminiferous tubules, which produce spermatozoa, and the endocrine interstitial glands, of Leydig, which produce testosterone. 1 to 4 highly convoluted, blindly ending seminiferous tubules are located in each lobule, where each tubule is lined by a seminiferous epithelium whose function is the production of spermatozoa. When produced and released from the seminiferous epithelium, the spermatozoa enter the straight tubuli recti connecting the open ends of the seminiferous tubules to a series of labyrinthine spaces within the mediastinum known as rete testis. The spermatozoa enter 10 to 20 short tubules, the Ductus Deferens, and form their entry to epididymus. Paired testicular arteries, arising from the aorta, follow the testes and Ductus Deferens, vas deferens, into the scrotum, providing a vascular supply to each testis. As the testicular arteries approach the testes, they become convoluted and are surrounded by the pampiniform plexus of veins. These convolutions and the plexus of veins form a system of counter-current heat exchange between these vessels that cools the temperature of the arterial blood to 95 degrees Fahrenheit, a necessity for viable sperm production. Together, the testicular artery, pampiniform plexus of veins, and Ductus Deferens form the spermatic cord, which passes through the inguinal canal. Hyperthermia is a major factor that results in sterility in men. More recent studies conducted with men using a laptop computer with the computer situated in their lap for an hour or more found that this contact with the computer caused an increase in intrascrotal temperature of 2.8 degrees Celsius. These studies are inconclusive, but it is advisable for boys and young men to avoid the use of laptop computers in their laps for an extended period. Cryptorchidism is a developmental defect in which one or both testes fail to descend into the scrotum. When only one testis fails to descend, the sperm in the descended testis usually is normal and fertile. When both testes fail to descend, the patient is sterile because normal body temperature inhibits spermatogenesis. Surgical procedures may be employed to correct this defect, but the sperm may be abnormal. Mutations in two genes, insulin-like factor 3 and HOXA10, are associated with bilateral cryptorchidism. There is a high incidence of testicular tumors associated with untreated cryptorchidism of the testis. Administration of hormones may induce descent, but when that fails, surgery is suggested. Seminiferous tubules. Each testis possesses approximately 500 sperm-producing seminiferous tubules, 30 to 70 centimeters long and 150 to 250 gm in diameter, embedded in a loose vascular connective tissue. The connective tissue wall of each seminiferous tubule, called the tunica propria, is surrounded by a basal lamina. The thick seminiferous epithelium, germinal epithelium, is composed of two different epithelial types, cerdola, supporting, cells and spermatogenic cells that are in the process of differentiation to form spermatozoa. Cerdola cells are tall columnar cells that possess large clear indented nuclei, abundant mitochondria, well-developed smooth endoplasmic reticulum, Golgi bodies, endolysosomes, and many cytoskeletal elements. The occluding junctions formed between adjacent cerdola cells subdivide the lumen of the seminiferous tubule into a basal compartment, basal to the tight junctions, which is exposed to the underlying vascular connective tissue. An adluminal compartment, which is isolated from the vascular connective tissue, establishing a blood testis barrier and protecting the developing gametes from being exposed to the immune system, which would otherwise mount an immune response against the developing gametes. The functions of cerdola cells are to support, protect, and nourish developing spermatogenic cells. Phagocytosed cell remnants, residual bodies, discarded during the process of spermiogenesis, facilitate the release of mature spermatids into the lumen of the seminiferous tubules via actin-mediated contraction, spermiation. Secrete androgen-binding protein, ABP, into the seminiferous tubule lumen, increasing testosterone concentration in the seminiferous tubules. Inhibin, which hinder the release of FSH. Fructose-rich fluid, which nourishes and transports spermatozoa along the genital ducts. Testicular transferrin, to assist in providing iron to maturing gametes. Antimullerian hormone, during embryonic development, which prevents the formation of the female reproductive system and permits the development of the male reproductive system. Spermatogenic cells, most of the cells composing the seminiferous epithelium are spermatogenic cells, Fig 21.4, see Fig 21.3, that accomplish the process of spermatozoon formation via the following three phases: spermatocytogenesis, the formation of spermatocytes; meiosis, the formation of haploid spermatids from diploid primary spermatocytes; and spermiogenesis, the transformation of spermatids into mature spermatozoa, sperm. Spermatocytogenesis, the formation of primary spermatocytes from spermatogonia, occurs in the basal compartment of the seminiferous tubule. Diploid spermatogonia sit on the basal lamina, and the presence of the hormone testosterone induces them to begin their mitotic activity. The three different types of spermatocytes are the dark type A spermatogonia, the least mature, are reserve cells whose oval nuclei are rich in heterochromatin, giving the cell a dark appearance. These cells enter the mitotic cycle to form more dark type A cells. Pale type A spermatogonia, whose oval nuclei are rich in euchromatin, giving them a paler appearance. Testosterone prompts these cells to undergo rapid cell division, forming more type A spermatogonia. Type B spermatogonia, whose round nuclei differentiate them from their precursors. These cells also enter the mitotic cycle to form primary spermatocytes. As these cells are undergoing cell division, they maintain contact with each other via cytoplasmic processes, forming a large syncytium. Meiosis is a reduction division that forms haploid cells. The large syncytium of diploid primary spermatocytes migrates from the basal compartment into the adluminal compartment of the seminiferous tubule and undergoes the first meiotic division. Secondary spermatocytes are in the adluminal compartment, and they undergo the second meiotic division, forming spermatids. Spermatids, haploid cells, are supported by cerdola cells while they undergo the final phase of spermatogenesis. Spermatogenic cells, 2. Spermiogenesis is the phase of spermatogenesis in which the spermatids lose much of their cytoplasm and are transformed into spermatozoa. The four phases of spermiogenesis are the Golgi phase, cap phase, acrosomal phase, and maturation phase. The Golgi phase, as its name implies, involves the packaging of hydrolytic enzymes by the Golgi apparatus into vesicles that fuse with each other to form the acrosomal granule containing acrosomal vesicle. Additionally, the flagella axoneme and connecting piece are in the process of formation. The acrosomal vesicle not only enlarges during the cap phase, but also attaches to and partially envelopes the nuclear membrane and becomes known as the acrosome. The nucleus of the spermatid becomes flattened and smaller, the entire cell becomes elongated, and the mitochondria collect in one location during the acrosomal phase. Additionally, a manchette, a temporary cylindrical collection of microtubules, is formed, causing the spermatid to increase further in length as it is being transformed into a spermatozoon. As the manchette dissociates, the annulus, which marks the junction between the developing spermatozoon's principal and middle pieces, is formed. Mitochondria assemble in the middle piece, and the outer dense fibers and the fibrous sheath are formed. The final phase of spermiogenesis is the maturation phase, when the spermatids release their excess cytoplasm, freeing individual spermatozoa from the syncytium. Spermatozoa are non-motile until they undergo capacitation in the female reproductive tract. Sertolith cells phagocytose the cellular remnants. This process is known as spermiation. Spermatozoa are haploid cells approximately 65 atm long that consist of a head and a long tail. The head of the spermatozoon, Fig 21.5, is less than skm in length and houses the haploid nucleus and enzyme-filled acrosome that contacts the nuclear envelope and the plasma membrane. As described in Chapter 20, when the spermatozoon contacts the ZP3 molecule in the zona pellucida that surrounds the egg, the sperm undergoes the acrosome reaction, releasing the enzymes, neuraminidase, hyaluronidase, aryl sulfatase, acrosin, a trypsin-like enzyme, and acid phosphatase housed in the acrosome. These enzymes degrade the zona pellucida in the path of the spermatozoon, making it easier for the sperm to reach and fertilize the egg. Tail of the spermatozoon, 4 separate regions constitute the tail of the spermatozoon. See Fig 21.5. The neck, interposed between the head and the tail, consists of the connecting piece whose 9 columns, surrounding the centrioles, persist as the 9 outer dense fibers. The middle piece connects the neck with the principal piece and ends at the annulus. It is composed of the mitochondrial sheath surrounding the outer dense fibers and the central axoneme. The principal piece begins at the annulus and ends at the end piece. It is composed of the axoneme enclosed by the 7 outer dense fibers that are encircled by a fibrous sheath. Near the distal terminus, the 45 gym long principal piece constricts in diameter because the outer dense fibers and fibrous sheath are no longer present. The end piece is the caudal end of the spermatozoon. It is composed of the central axoneme, with its conventional 9 doublets and 2 singlets, but becomes disorganized at the terminus into a cluster of individual microtubules. Mumps, a systemic viral infection, produces a 20% to 30% incidence of acute orchitis, inflammation of the testes, in postpubertal men. Generally, spermatogenesis is not cycle of the seminiferous epithelium. Germ cells derived from a pale type A spermatogonium are closely held together as a syncytium whose members communicate with each other and synchronize their development into 6 stages of spermatogenesis, Fig 21.6, as they develop into spermatozoa. Each stage appears to last 16 days and is called the cycle of seminiferous epithelium. The completion of spermatogenesis requires the passage of 4 cycles, 64 days. Interstitial cells of Leydig, the richly vascularized loose connective tissue surrounding seminiferous tubules, also houses small groups of large polyhedral endocrine cells, the interstitial cells of Leydig, Fig 21.7, which produce testosterone, the male sex hormone. The cells of Leydig are characteristic steroid-producing cells containing abundant smooth endoplasmic reticulum, numerous mitochondria with tubular cristae, and crystals of Reinke, whose function is unknown. Testosterone is believed to be released as it is being synthesized. These cells do not exhibit secretory vesicles. Clinical considerations. Chemotherapy treatments for cancer in young male patients may render them aspermatogenic because spermatogonia undergo mitosis and spermatocytes undergo meiosis, which can be affected. Dormant stem cells that are not currently involved in DNA synthesis and the cell cycle may be able to repopulate the seminiferous epithelium when anti-cancer chemotherapy is discontinued. Affected by this disease, Clinofilter Syndrome results from an abnormality known as non-disjunction that occurs during meiosis, where the XX homologues fail to pull apart, producing an individual with an XXY genome, an extra X chromosome. These individuals have mental retardation, are infertile, are tall and thin, and display weakened masculine characteristics including small testes. Histophysiology of the testes: each testis produces approximately 100 million spermatozoa per day that are nourished and transported into the genital ducts by the fructose-rich medium produced by the Sertoli cells, Fig 21.8. The process requires the actions of luteinizing hormone, LH, and follicle-stimulating hormone, FSH. The mechanism of hormonal control of spermatogenesis is illustrated in Figure 21.9. LH derived from the adenohypophysis activates the interstitial cells of Leydig to form the male androgen, testosterone. The mechanism of testosterone synthesis and release is illustrated in Figures 21.8 and 21.9. FSH, also derived from the adenohypophysis, stimulates Sertoli cells to manufacture and discharge androgen-binding protein, ABP, which binds to testosterone and prevents it from leaving the seminiferous tubule. The increased level of testosterone in the region of spermatogenesis stimulates the process of spermatozoon production. The hormones testosterone and inhibin, secreted by Sertoli cells, stimulate a feedback mechanism to inhibit LH production. Testosterone is also necessary for the proper functioning of the seminal vesicles, the prostate gland, and the bulbourethral glands, responsible for the male sexual characteristic and appearance. Testicular cancer is much more common among white men than men of African or Asian descent. Although a rare disease, testicular cancer is the most common form of cancer in men 20 to 34 years old. Testicular cancers arise from germ cells of the seminiferous epithelium 95% of the time and from the interstitial cells of Leydig approximately 5% of the time. There is no known cause, but the following conditions may predispose an individual to being affected by this disease: cryptorchidism, Clinofilter syndrome, and a family history of testicular cancer. Symptoms include size change in one or both testes, with or without pain, heavy feeling in the scrotum, and dull pressure or pain in lower back, stomach, or groin. Diagnosis is by blood tests and imaging tests. Treatment includes surgery, chemotherapy, and radiation therapy. Testicular cancer can be cured if treated early. Male genital ducts: the system of male genital ducts begins in the testis, with intratesticular ducts, and is continuous with the extratesticular ducts that end at the prostatic urethra. The intratesticular ducts are the tubuli recti and redi testis, Fig 21.10 and Table 21.1. Tubuli recti are short, straight tubules that convey spermatozoa from the seminiferous tubules into the redi testes. Their proximal half is lined by Sertoli cells, and their distal half is lined by a simple cuboidal epithelium whose cells possess short microvilli and frequently a single cilium. Redi testis occupies the mediastinum testis and is a labyrinthine system of spaces lined by a simple cuboidal epithelium. The cells of this epithelium are similar to the ones that line the distal half of the tubuli recti. The extratesticular ducts are the epididymus, Ductus Deferens, Vas deferens, and Ejaculatory Duct. The epididymus is composed of two parts, the Ductuli efferents and the Ductus Epididymus. The 10 to 20 Ductuli efferents are short tubules that convey spermatozoa from the redi testis into the Ductus Epididymus. These ducts are lined by a simple epithelium whose cells form a festooned appearance because of the alternating patches of simple cuboidal and simple columnar cells and reabsorb some of the fluid in which the spermatozoa are suspended. Deep to the epithelium is a basement membrane that separates it from the connective tissue, which is enveloped by a thin layer of circularly disposed smooth muscle cells. The ductus epididymus, is a tube approximately 4 to 6 m long lined by a pseudostratified stereociliated, long, non-motile microvilli, epithelium. The wall of the epididymus houses circular layers of smooth muscles whose peristaltic contraction facilitate the delivery of spermatozoa into the ductus deferens. The epithelium is composed of two types of cells, regenerative basal cells and stereociliated principal cells that resorb fluid from the lumen, and secretes glycerophosphocholine, which makes the spermatozoa infertile until capacitation occurs in the female genital tract. The ductus deferens, vas deferens, has a small, irregularly shaped lumen and thick muscular wall and conveys the spermatozoa from the ductus epididymus to the ejaculatory duct. The epithelial lining is pseudostratified and resembles that of the ductus epididymus with shorter principal cells. The smooth muscle coat has inner longitudinal, middle circular, and outer longitudinal layers. The terminal portion of the vas deferens, the ampulla, is dilated and is joined by the duct of the seminal vesicle to form the ejaculatory duct. The short ejaculatory duct, lined by a simple columnar epithelium, has no muscle cells in its wall. It pierces the substance of the prostate gland and delivers its luminal content into the collicula seminalis of the prostatic urethra. Vasectomy is chosen by more than 600,000 American men annually as a means of contraception. This brief surgical procedure is nearly 100% effective and is intended to be permanent. The vasectomy procedure is uncomplicated and commonly performed in a physician's office. The nascalpal method is most often used, in which the scrotum is punctured, and a loop of the spermatic cord is retrieved, cut, and cauterized and then returned to the scrotum. Semen is collected and examined under a microscope after approximately 6 weeks and possibly later on a surgery to ensure that no sperm remain. A few complications may be experienced, but most are transitory. Accessory genital glands. The male accessory genital glands are the paired seminal vesicles, bulbourethral glands, and the single prostate gland. The right and left seminal vesicles, long coiled ducts located posterior to the bladder, join their respective ductus deferens to form the two ejaculatory ducts. The pseudostratified columnar epithelium of the seminal vesicles is composed of regenerative basal cells and columnar cells, whose height is a function of the local testosterone concentration. Each columnar cell possesses short microvilli and a single flagellum. The fibroelastic connective tissue that underlies the epithelium is enveloped by an inner circular and an outer longitudinal layer of smooth muscle tunic. These glands manufacture a yellow, fructose-rich fluid that also contains amino acids, proteins, citrate, and prostaglandins. The seminal vesicle secretion constitutes 70% of semen volume and provides nutrients for the spermatozoa. The two small bulbourethral glands, Cowper's glands, lined by simple cuboidal to simple columnar epithelia, lie next to the membranous urethra and deliver their galactose-rich and sialic acid-rich viscous, slippery secretion into its lumen, lubricating it. The fibroelastic connective tissue capsule of the gland possesses smooth and skeletal muscle fibers. The single prostate gland, Fig 21.11, normally the size of a horse chestnut, completely surrounds the ejaculatory ducts and the prostatic part of the urethra. Its fibroelastic capsule interspersed with smooth muscle cells, invades the substance of the prostate to form the stroma, which also is enriched by smooth muscle cells. The glandular parenchyma is composed of 50 compound tubuloalveolar glands organized in 3 concentric layers, innermost, immediately surrounding the urethra, mucosal, the shortest glands. Main glands, which are the outermost glands and constitute most of the prostate. Submucosal glands, which are intermediate in size and location, occupying the region between the mucosal and main glands. The parenchyma of the 3 glands comprises a simple to pseudostratified epithelium whose cells are well endowed with rough endoplasmic reticulum, Golgi apparatus, lysosomes, and secretory vesicles. These cells manufacture a watery secretion whose release is promoted by dihydrotestosterone and that is composed acid phosphatase, citrate, lipids, proteolytic enzymes, and fibrinolysin. Frequently, Especially in older men, the lumina of these contain calcified glycoproteins, prostatic concretions, corpora amylacea. The release of the secretions of the accessory genital glands occurs after erection. The bulbourethral glands are the first to release their slippery lubricant shortly after erection, whereas release of the spermatozoa from the ampulla of the Ductus Deferens and the secretions from the seminal vesicles and the prostate occurs directly before ejaculation. The semen that is ejaculated is approximately 3 ml in volume and contains 200 to 300 million spermatozoa suspended in the secretions of the accessory glands. The penis has a dual function: the delivery of urine to the outside and the conveyance of semen into the female reproductive tract. The penis is the copulatory organ and is composed of 3 masses of erectile bodies, Fig 21.122 dorsally placed corpora cavernosa. Single, ventrally positioned corpus spongiosum urethrae, whose distal terminus is the head of the penis, known as the glans penis, which displays a vertical slit, the external opening of the urethra. All 3 erectile bodies possess their own tunica albuginea, a fibrous connective tissue capsule, and the 3 suctures are invested by a tubular sheath of thin skin that extends over the glans penis as a loose retractable sheath, the prepuce. The erectile tissues of the penis are composed of irregular, labyrinthine, endothelially lined vascular spaces that are bounded by connective tissue trabeculae enriched with smooth muscle cells. The 2 corpora cavernosa have vascular spaces of variable size that are smaller at the periphery and larger near the center. Have fewer elastic fibers and more smooth muscle cells in their trabeculae. Receive their blood supply from the deep artery and the dorsal artery of the penis, which pierce the trabeculae and form capillary beds and helical arteries. The helical arteries play a major role in the erection of the penis. The corpus spongiosum urethrae has comparable sized vascular spaces centrally and peripherally, has fewer smooth muscle cells and more elastic fibers than the corpora cavernosa, is surrounded at its proximal terminus by the powerful bulbospongiosus muscle, skeletal muscle. Venous drainage of the erectile tissues of all 3 erectile bodies and of the glans penis occurs via 3 sets of veins that are tributaries of the deep dorsal vein. A normal single ejaculate contains approximately 70 to 100 million spermatozoa per milliliter. A man with a sperm count of less than 20 million spermatozoa/ml of ejaculate is considered to be sterile. Mechanisms of erection: ejaculation and depumescence. Blood flow in the flaccid penis is redirected to arteriovenous anastomosis between the arterial supply and the venous drainage, preventing the flow of blood into the vascular spaces of the erectile bodies, Fig 21.13. When the blood flow is altered so that instead of entering the arteriovenous anastomosis it flows into the vascular spaces of the erectile tissues, the penis becomes erect and the tunica albuginea of the erectile bodies becomes stretched. Erection is achieved by sexual stimulation, whether tactile, visual, olfactory, or cognitive, which engages the parasympathetic nervous system, inducing the release of nitric oxide from the endothelia of the deep and dorsal arteries of the penis, causing a relaxation of the smooth muscles of the tunica media of these vessels, increasing blood flow into them. Simultaneously, the arteriovenous anastomoses become constricted and blood enters the helical arteries, which deliver their blood into the erectile tissues. The erectile tissues become turgid, compress the veins, and impede the outflow of blood, and erection is maintained. If the glans penis remains stimulated, the bulbourethral glands release their slippery secretion, the secretory products of the seminal vesicles, along with the spermatozoa in the ampulla of the Ductus Deferens, into the ejaculatory ducts. The prostate releases its secretion into the prostatic urethra, and the semen is ejaculated, a process that is under the control of the sympathetic nervous system, as follows: smooth muscles of accessory glands and genital ducts contract and convey semen into the urethra. Sphincter muscle of the urinary bladder contracts to prevent leakage of urine. Bulbospongiosus muscle contracts rhythmically, expelling the semen from the urethra. Depumescence occurs after ejaculation because the parasympathetic nerves no longer induce the release of nitric oxide in the deep and dorsal arteries of the penis. The reduced blood flow into these vessels permits the opening of the arteriovenous anastomosis. Drained blood from the vascular spaces of the erectile tissues results in the penis returning to the flaccid state. Erectile dysfunction has nervous system involvements, including disturbances along the cerebral cortex, hypothalamus, spinal cord, autonomic nervous system pathways, and problems arising from vascular diseases. Additional causes include stroke, head injuries, spinal cord injuries, and anxiety disorders. Numerous systemic diseases, such as Parkinson's disease, diabetes, and multiple sclerosis, may also lead to erectile dysfunction. Sildenafil, Viagra, was originally developed as a drug to treat heart failure. Patients who were previously impotent and were treated with this drug reported, however, that they were experiencing erections. From these observations and subsequent clinical studies, sildenafil became a drug of choice in the treatment of impotence. Numerous similar drugs have been developed that are also able to restore the ability to achieve erection in patients who are impotent.